Hello, everyone. Welcome to the July meeting of Plan, Design, and Expenditures. Happy to have you all here, and I hope you're all looking forward to a nice holiday weekend. Let's get started with roll call.
We will need just a little bit of time for that.
Oh, you're still letting people
we just
in?
have to, well, it's more that you have to let them have permission to speak. You have to do everyone individually, so it takes a minute.
Okay, we'll give it a minute then. We may have a short meeting today, depending on how much discussion that we have. Maybe while we're letting people in, I'll just let you know we've had 2 pieces of public comment that came in written form. And so the first one was just general support for our work and encouraging us. And the second one encouraged us to consider the subscription model of medical practices where patients pay a monthly fee to get access to a primary care provider. I think that's also called a concierge model, that they expressed enthusiasm and support for that work. And then we will have time for oral public comment at the end of our meeting today. Mostly we're going to be talking about today is provider payment and different strategies for how providers might get paid, possibly get into a little bit of how regional entities would work and how quality fits into that discussion. So we have a presentation from our subcommittee and hopefully plenty of time for a good discussion. So Isabel, let me know when you're ready for a roll call.
Just 1 second. We're admitting the last people.
You definitely have a quorum, though.
Yes, we do. I think we can get started with the roll call. So Helen Blanca.
Here.
Chen-Wei Chi. Don't see him. Peter Addy. I see you and I'm giving you permission to unmute. Okay.
Here, present.
Thank you. Gabrielle Andine.
That's me.
Thank you. Betsy Boyd Flynn. I see you in the list, so if you're able to unmute and let us know that you're here.
Can you hear me? I'm here.
Yes, I hear you. Thank you. Mike Durbin.
Here.
Thank you. Rob Fizette. Don't see them. Tony German.
Here.
Thank you. Eve Gray.
Present.
Thank you. Rosemary Hemmings. I don't see them. Julianne Horner. Don't see their name. Max Kaiser.
Here.
Thank you. Jim McGee.
Here.
Thank you. Peter Merritt.
I see Peter. He hasn't been unmuted yet.
I will give you permissions. Thank you. Peter Merritt.
I do see a hand up there for Peter, so.
Yep.
I'm here. Thanks.
Thank you. Angela McCallick.
Here.
Thank you. Jamie Osborne. Here. And Tosh Rahman.
Here.
Thank you.
Great. So I've already gone over the agenda review briefly. I'm going to hand it over at this point to Director McDonald to talk about previous meeting and committee updates.
All right. Hello, everyone. Happy to see everyone here again. So we'll talk a little bit just about some of the high points from our last meeting. So the eligibility straw proposal was created and further developed with the committee recommendations. It was reviewed by the board on July 12th. The board asked for some clarifications regarding the definition of Oregon resident, and to ensure that the CFR and ORSs that were referenced are in compliance with federal and state regulations. And so that that document, so the board said, gave its approval, sort of pending these clarifications. And currently now the document is in the hands of our DOJ partners. So they're looking at it. The board was also asking information about current eligibility confirmation for new enrollees in any of the Oregon Medicaid programs, which staff is developing. Of course, you guys may know that some of the requirements certainly may be changing based on federal guidance coming up in the next little bit. So that's our eligibility part. And then the next slide, please. All right, and again, as you remember, we had some fantastic presentations on provider reimbursement models around behavioral health, primary care, and then ACO models. And the committee in general requested additional information regarding these payment models, certainly from different countries with universal health care, and also about value-based payments and risk contracting. So a lot of that information was collated and then submitted to the subcommittee, who's had time to look over it, and excited to say that you will get to hear from your subcommittee very shortly. So we'll go on to the next slide. Okay, next one. So again, just trying to keep all of the committees in the loop of what everyone is doing, just having a quick update. The Community Engagement and Communications Committee has done a substantial amount of work on a style guide that can be used for all 4 UHPGB documents that are going out, that will eventually go out to the general public and also internally, ensuring we have inclusive and trauma-informed verbiage. They are in their 3rd iteration, but it's an amazing work in progress, so very exciting work. And happily, Patty Wentz, consultant, has started working with the committee as of June 25th, and she will be working on informational materials in the communication plan with the CECC. Operations, the trust fund proposal was approved by the board. They are also have been working on some of the, you guys, people may have heard about that there was a question about if revenue sources that came from personal income tax through Oregon and went into the trust fund, if those would be potentially subject to the Oregon surplus refund, as we lovingly know as the kicker. And actually the operations committee and staff have worked with DOJ, and it is good news that it appears that the that trust fund and the funds that go into it can be created in such a way to not be subject to the kicker. So that's actually good news. Operations is also working on some of the IT infrastructure needs. They're also waiting for the Milliman Consultant Group for that contract to be finalized. And then lastly, Finance and Revenue agreed upon a funding target, which has been helpful. And now they're working on revenue plan structure. So looking at a lot of different options, kind of, I would say, basing them, that additional revenue that's needed, mostly basing it on different variations of personal income tax and then employer taxes, and as kind of as the foundation, and then other potential taxes. So that's still a work in progress. Any questions about any of the committee work? Okay, next slide. Okay, I'm going to turn it over to Helen Blanca.
Great. Thanks, Mimi. So before we get started in this discussion about provider payment, I just want to make a few comments about it. How clinicians, hospitals, and institutions are paid in our healthcare system is incredibly complicated. And there is good reason to assume that even with the universal health plan structure that we're coming up with, those payment structures will remain pretty complicated. There are so many different pathways for payment, including global budgets and value-based payments. There's still a fair bit of fee-for-service going on. There's capitation. There's risk that's borne at all kinds of levels, from the provider to the institution to insurance companies, and then payments for things other than direct services. So payments for infrastructure and payments for enhanced coordination of care. So the payment system is very, very complicated. And like I said, it likely will remain so. And so when we start talking about how providers are paid as part of this committee, I want to make sure that we maintain an appropriate scope. And we can debate this, but just as a starting point, I would like this committee to really focus our efforts on primary care payments. How primary care is paid in a universal healthcare system, I think, is going to be the cornerstone of how the whole system would work. And it is a really important piece of the system to think through to make sure that we're getting it right. How hospitals are paid, how specialists are paid, how ancillary services are paid, those all still need to be worked out. And it's possible we'll bring those at a later time to this committee. It's possible those will be worked out and resolved through other mechanisms, including engagement with those groups. But for right now, I think that focusing on primary care and then behavioral health care are the two ways that this committee can really make an impact on the board's work. Behavioral health payment, we've already discussed a fair bit about in terms of the benefits when we had that discussion. But we have a specific charge with this board to really enhance and improve the way behavioral health care is accessed and delivered in our state. That's one of our prime motives for this work. And so thinking about how primary care is delivered, how behavioral health care is delivered, and how those two interact is really great. We have these two models that we've talked about previously, PCPCH, which is the patient-centered primary care home, and CCBHC, which is the behavioral health, the community. I always get that first C wrong.
Certified. It's the certified.
Certified community behavioral health centers. Yeah, the certified community behavioral health centers. They have really similar models. They're sort of like inverses of each other. So certified community behavioral health centers primarily offer behavioral health, but they bring in primary care and do a lot of wraparound services for this severely behavioral health challenged folks in our community. So those two models are really great models that have been well developed in our state that we want to capitalize on and enhance. And so when we think about payment models, thinking about how those systems work and how they could be paid is really where I want this discussion to focus. As we do that, we should think about how different payment strategies affect quality and how they affect what they incentivize, right? Because depending on how you pay providers, you will be incentivizing different things. Historically, fee for service incentivizes quantity of services. The more visits, the more procedures you do, the more you get paid because you get paid by the service. Capitation incentivizes fewer visits because you get paid a set amount. And then if you save money, then you get to hold on to that amount. So capitation incentivizes fewer visits and avoidance of very sick patients. So the highest risk, highest need patients it's hard to make sure that those folks are cared for in a capitated system. So different ways of payments are going to incentivize different things. And so we should keep that in mind. And then overall, our goals in this work are to, like I said, center primary care and behavioral health, to simplify the system, to make it easy for both patients and clinicians to participate in, to provide better access for patients, and to provide a better work environment. I don't think we will be successful unless we acknowledge that our primary care workforce is really struggling right now, both in terms of numbers, we don't have enough primary care providers, and in terms of the work environment itself. What we ask of our primary care providers is enormous, and it's a very stressful job. And primary care clinicians leave pretty frequently. The turnover is rough. They don't often, as often as we'd like, stay for their full career in primary care. And then, of course, saving money, doing things in a way that's efficient and will make better use of our shared resources as a state is a goal. Before we move on from there, does anyone have any questions about that scope, orientation, level setting? And I can't see hands, so somebody tell me if somebody's raising a hand.
No hands yet.
Cool. Excellent. Okay, so then we can move on. I want to just start by saying we are incredibly grateful to the subcommittee who offered to look into provider payments in more depth. And we really value your time and your efforts on the behalf of this committee. And all subcommittees, including this one, their job is to do some research and bring ideas forward to the bigger committee. And then we will come up with recommendations and decisions as a group. Subcommittees on their own don't come up with recommendations, but they do some background research and bring information to the committee. So I will hand it over to Tony German.
Thanks, Helen. And great to see everybody today. Yeah, I'll just jump into our subcommittee and so we were able to meet twice in the interim from the last plan design and expenditure meeting, had an hour each time, some very productive conversations and looking at the charge and beginning the conversation surrounding outpatient ambulatory settings for payment and looking at an investigation of what further information the larger group could value in looking at it. We had a presentation in June that was really helpful in grounding us in thinking of different structures across the country, and have some ideas perhaps to bring to the larger body. We are looking forward to meeting this upcoming month and trying to get some meetings together. I'll just say summer is a hard time for everybody, vacations and whatnot. So that presented a bit of the challenge, but we're navigating through those. But again, some really productive conversations, and we can jump into the next slide. So, at the start, what we wanted to, and Helen, you alluded to a number of the points, but we thought when we're getting into this body of work, thinking of really what are the principles that we want to bring forward as a subcommittee to a larger group, and really valuing and elevating the work that is taking place across Oregon, but also setting the stage for, as we make proposals for the governance board and bring forward and maybe put this into place, how do we continue to prioritize innovative environments for Oregon to not just be set forth and not be dynamic, but continuing to think of other ideas that we shape form. Payment has changed remarkably in the last several decades, and particularly in the last decade, and inclusion of new strategies to incentivize good patient outcomes and community benefits. So we really want to make sure that we're setting the stage for that. Ultimately, really what a larger goal, I think, for us moving forward as a state to implement a universal healthcare system is simplicity. And that really comes with the acknowledgement that we have a workforce that is challenged to continue to deliver the care. And some of that is in the payment models that we see in the duplicative efforts and the way that we get paid. And so thinking about how do we simplify that payment? What are the trade-offs with the differences that we see? And really acknowledging again that coordination of care has been really a strong theme for the state of Oregon and with our CCOs and thinking how is that delivered, one, on savings for us as a state and taxpayers, but delivering again, looking at keeping people out of the hospital, keeping people out of the emergency departments, making sure people that are getting team-based care, and we've really adopted that. So that's something we've been putting forward. As mentioned, we think the bedrock of a healthcare system that is highly functional incorporates primary care and really promotes that, as well as augmenting where we need to go for incorporation of behavioral health embedded into that. In our charge is that we think that there's a lot to learn, and there are a lot of good ideas that are going across the states. And so we actually have some ideas that we'd like to present to the group today of some future pathways to do some further investigation. And of course, looking at other countries. There is a great body of work and a lot of health policy changes that have taken place in a number of different nations that have some really best practices and demonstrate some really good quality outcomes and support for their nations. And so that's all of the piece that we want to incorporate in sharing today. And And then finally, we want to be cautious in how much we're altering the system. We need this to be transformational. As anything is evidenced today at HR1 passed. And so we're going to see really detrimental effects in the coming years. And thinking about the impacts of all the incremental reforms that we've done as far as the Healthier Oregon program, the Bridge program, expansion of Medicaid, exchanges, all of those have been helpful. But we're seeing the house of cards fall, and we're going to see really some more concerning features in the coming year or two. And really, our charge is to be transformational, but an acknowledgement that we can't rock the boat too much. We also need to be aware of how we operationalize this and make sure that it is something that existing health systems and clinics can make this transition. And we know that the operations side of the governance board is really taking that on, but we want to be thoughtful in the subcommittee work too. So next slide. What we thought was really helpful is to ground people. I know many people are well versed in these terms, but as we move into this, I think the details matter. And so just wanted to refresh people's memories regarding some of these approaches that we've taken in our own state and across the United States and across the world, and how a healthcare provider or health system gets paid. And we can jump into the next slide that has a little more detail on these. I know this is quite busy, and I think people got slides, I think, over the last couple of days with this. And I think people are really familiar with this, but, bird's eye view here, fee for service, is very transactional. Really, in essence, if I put in an IUD, I deliver a baby, do a surgical procedure, I get paid for that certain amount for that. As mentioned, this leads to the potential for higher utilization, higher lack of awareness of the total cost of care, and more just on volume, right? The other model is capitation, which really is, for simple math, let's say my clinic takes care of 10,000 patients, that for each patient that is assigned to us, we have a certain amount of money per patient per month. And we're invested in taking care of the holistic approach to that patient's care, and paying attention to whether they seek care outside of our clinic walls, and that can be in an emergency department or in a hospitalization. And so it incentivizes a group or health system to ensure that that patient is getting in and that we're addressing their chronic health needs. Salaries, everybody's pretty familiar with what a salary is. A global budget really is just a lump sum of money that can be distinguished to a geographic region, to a group of providers. In the setting, often we see this a lot in hospitals. That allocation of money is usually pegged to prior years in how much spending was in historically, and then can be move upward as far as inflation, or pegged to other measures of how that would increase. Pay for performance is something we're seeing certainly the last decade more, and this can be provided in a number of different ways. Essentially looking at certain factors, and we do this, for an example, would be our coordinated care organizations. What that is we have a set of metrics, and that could be, an example would be diabetes control, promoting interventions as far as a clinic or provider to reduce someone's A1C below 9, and that certain percentage is evaluated. And then if you meet that mark, then you can get a bonus, essentially, as far as in that reimbursement. Others that we have in there is depression remission, immunizations, a whole multitude of those. The challenge with our healthcare system is that a lot of systems have over 200 of these when they look at the breadth of a number of different insurers and payers for that. Bundled payments really are really related to sometimes in the setting of like a hospital setting, but could be for something like a pregnancy, where the totality of the prenatal care and then the subsequent delivery is bundled in that as probably one of the more common ones and familiar ones we're used to. But it could be something where somebody enters a hospital and they get something like a diagnostic related group, whereas if you come in for pneumonia, it's expected on average that the treatment and the cost of that care should be fairly similar, and there are going to be differences in outliers, but on the whole, those should be similar to that. We're going to jump into the next slide and talk a little bit about some comparisons internationally in ambulatory settings. And we thought that this was productive because these were some of the nations that are standouts, that have controlled cost, and that have high patient satisfaction, have really demonstrated good clinical outcomes as well. So in the left side, you'll see just general primary care payment. We also thought it was important to call out as far as specialty care and outpatient setting as well. And you'll see there's some changes here in how some of these systems pay that, and some are embedded within a hospital system, but some of them remain outpatient pay as well. So in Canada, primary care payments are mostly fee for service. However, there are some new demonstration products that are going on, and these are respective to different provinces that are attempting to do more adoption of value-based care and incorporation of capitation payments. They also have a mixture of salary as well. In the specialty sector, most of that is fee for service, but they do have some capitation as well and salary, so it's a large mix in that sector. In Taiwan, it really is fee for service for the large majority of care, and really only less than 1% is paid for in a setting of capitation or pay for performance. Outpatient specialty care as well is largely fee for service, and with some copays that vary with the different referral networks. In the UK, it is a mix of capitation, fee for service, all of the above. And so a large mixture, and that we would kind of describe as a hybrid model. And you'll see a theme here where a lot of nations have been moving more towards a hybrid incorporation of a number of these features of payment. In the UK, largely salary for specialty care. In the Netherlands, same idea, mix of capitation, fee for service, and bundled payments. For specialty care, salary largely. In Sweden, mostly capitation with some small amount of fee for service, and a little of the pay for performance and population health. And then global payments on per case payments, so those bundled payments for specialty care in Sweden. Go to the next slide. We thought it'd be ideal to give a bird's eye view of where total cost of care comes in Oregon as compared to the United States as a whole. I'm thinking of where our spending comes from. You can see the majority of our spending comes from hospital care, as one would expect. And paired with that, it's hard to distinguish out in this slide as far as clinical or provider payment, because some of that will take place in the hospital as well as in the outpatient setting. You can see nursing homes as well as prescription drugs and medical non-durables. Smaller amounts spent for dental, home health, DME, and other related personal or other spending in those sectors. Next slide. One distinguishing feature, we talked a little bit about this in the last meeting, is some different approaches to management of care. And we heard about accountable care organizations and projects that had been taking place with the CMMI, the Centers for Medicare and Medicaid Innovation. There is another flavor of our alphabet soup called Administrative Service Organization. And we like to compare and contrast this because we think that this has some merit for us to do some further investigation. And so an administrative service organization really is a third-party entity that manages administration and care coordination functions on behalf of a state without, and this is a key distinction between an ACO and an ASO, is who's assuming financial risk for the medical services. They are non-risk bearing. So unlike our CCO, our coordinated care organizations, and that of an ACO, an ASO does not bear the risk for that delivery of, or payment for that care. However, they're really involved in the care management and coordination among the network of providers, including coordination with other care settings such as hospitals or emergency departments. And they also help have oversight in the utilization management in looking of what care can be provided and what has limitations and further restrictions on that. Next slide. This is just a graphic just to share, compare and contrast a little bit more who's delivering the care in both settings. ACO, ASO, you see delivery and that care coordination and management of those services. The call out here is the financial risk. In an ACO, you do share that risk, and there are different models of these where there is just an upside risk and a two-sided risk where a healthcare provider or health system can be involved with the ACO. So pay for performance would be something, an upside risk. If you're able to deliver on good quality outcomes, you get positive payment for that. And a two-sided risk, if you have more patients that go into the emergency department or in the hospital and you're losing, you have more spending in that, then you are challenged with further losing money in that construct. Again, in the ASO, there is not financial risk with this, so there is no payment loss in that setting. ACOs are largely value-based care in the population health. In an ASO, predominantly, it is a fee-for-service approach. However, the one we're going to talk about in a sec is the state of Connecticut, and they do have some models of a hybrid payment structure with capitation involved in that. The participants are providers in the health system and the insurer in the ACO. With the ASO, it's really just a third-party administrator having oversight. Accountability, ACO is with all parties, and really in the ASO, it's really accountable to the administrator to have that oversight and provide that feedback to the healthcare providers. Both care coordination, as I mentioned, in both sectors, and shared analytics and data in both of them. I'll go to the next slide. The call out here is an interesting model that's taking place across the other side on the eastern seaboard in Connecticut, is looking at what Connecticut has done for their Medicaid population. It was called the Husky Plan or Healthy Husky Health. They traditionally really have done fee for service for the lion's share for the last 13 years or so. But they switched from a managed care organization managing and having financial risk in this construction of their Medicaid delivery plan and went to an ASO model. The Husky Health is self-insured at the state level. And it's overseen by the Connecticut Department of Social Services with 3 different ASOs. I believe it's a community health network and incorporates dental and behavioral health as well. The call out here is that Connecticut over time, over the last decade or so, has really been able to freeze or slow their growth of spending. And spends only 3% of total costs on administrative expenses, and that's how they've done that, and saving the state comparatively what they would have done the counterfactual in reports, a number of millions of dollars. And then I think this might be our last slide. Yeah. So, I think what our interest is just this was a bird's eye view, right? We don't have any answers yet to bring to committee. As I mentioned, we were limited a little bit in our time, but we're hoping and a request is to investigate further our Connecticut partners. We also are very interested in, and it's lovely to have Dr. Chi in our ranks and explore what Taiwan is doing with regard to provider payment, and hoping to have some connection with him. We also, in our own backyard in Bend, looking at some ASO models and ACOs, looking at those, but we would like to do a little more investigation and more specificity, and share at the next meeting the trade-offs in some of these models, and bring that forward. And looking at the question that Dr. Blanca mentioned is, how do you ensure the integrity of quality of care and total cost of spending in some of these settings where if we were to move more of a model of fee for service in some of these versus maintaining the integrity of some of the sectors of hybridization where we have a capitated model with pay for performance and bundled payment. So looking to bring more information back, and I will pause for questions.
I have a question. This is Helen. Thanks, Tony. That was fabulous overview. Is the Husky Health, is it for is it Medicaid or is it like all payer system? Who's under that system?
Yeah, so it is the total Medicaid population management. So it's all of their Medicaid.
Yeah, so it's similar idea to what we did with CCOs, except they took the risk bearing out of the entities. Is that right?
Correct.
But they're like, are they they're regional entities? Are they geographically defined? Do you know, or how are they defined?
This is the part where I don't want to give. I don't know the answer to that, and so that's why I think it warrants further investigation and clarity on that, because I think it is a model that has a lot of promise.
Yeah. Okay.
And I would encourage my colleagues on the committee to help me out here on these. I see Eve, but Peter, you had a question.
Yeah, thank you. A very dense, informative presentation. Two things. At the very beginning, you said, considering other bills that are happening federally, we can't rock the boat too much. And I just wonder why. I think that now is precisely the time to rock the boat and to do as big and robust changes as we can in order to protect the population as best as we can. So I think this is exactly the time to rock the boat. And then I was wondering too, when you're looking at different countries, I know I've asked this before, but could you or do you plan on looking at China or Cuba or Vietnam?
I think those are excellent observations, and I'd be interested to explore those further. So we'll add those to the list. With regard to your first question, I think the conversation that we shared as a subcommittee is, and I agree with your sentiments. I'm quite frustrated by today. I have a smile on my face, but I think the sentiment from today, I have a lot of adjectives to share, and I agree with you. The consideration, I think, is we need to be thinking about in operations as a transition to, and thinking about how do we get from point A to point M. And perhaps that the first go isn't all the way there, but thinking of innovative strategies that we might look at moving us towards that. But we got to get through B, C, D, and all the way through. And actually, Eve is very articulate at this, much better than I am in saying this, because we've had really good conversations on this. But that, I think, is kind of where I think we were coming from.
Yeah, I agree. And I think a lot of the sentiment in the don't rock the boat too much, it comes in the conversation around specialty care. Because I think our primary care providers are pretty accustomed to working in different models now, you know, exploring value-based care, fee-for-service capitation. And hospitals, I think, will be largely jumping for joy with the idea of a global budget, which is, you know, I think largely what we've been talking about. Talking with the hospitals in our area, it's just not working for them right now. And you can't make the incentives appropriate because the only way they make money is to perform surgeries. And then it's difficult to move a lot of the surgeries where they really belong. We have increased cost in the system. So I don't necessarily have concerns about being creative in those areas. What I do worry about is that specialists, whom we still really, really need in this state, will flee. You know, surgeons who are accustomed to the harder I work, the more surgeries I do, the more money I make. Something like a salaried model, I think, would, for some, be pretty threatening. And so knowing that this change that we're talking about is not a foregone conclusion. It still needs to make it through a whole lot of barriers before we get to the reality that we're hoping for. How do we minimize the opposition and help lead folks through the change with us to see that the sky is not falling? There's still going to be good, solid reimbursement, that the salaries that particularly specialists are accustomed to are not at risk. Those are things that I think we have to balance, because otherwise the thing will get stalled before it ever starts, as opposition begins to rise. So that's the concern there. And then Helen, in terms of your question about regional models versus not, I think one of the things that I said in the subcommittee is that we like to share that in Lane County, we are the size of the state of Connecticut. So I think there is more statewide stuff that happens in Connecticut, but when you take that and you layer it into Oregon, the situation looks a lot different. So I think we talked about preferring regional models just because of the incredible diversity that we have within our state, and a sense that when it's statewide, there tends to be a lot of focus on the needs of the metro area, and the rest of the state tends to feel left out. So anyway, that would be my thoughts there. I think the only other thing I would add is it makes me a little anxious that dental is out of scope. I see dental as primary care. And actually, I see vision as primary care too. So I feel like we need to talk about it holistically, that if you don't have a healthy mouth, you don't have a healthy body. And so thinking about that with the integration of behavioral health, dental, I like to see it more of a package personally.
Yeah, let me jump in here for a second. Yes, thank you for that. By out of scope, I don't mean out of scope of the model. I just mean out of scope of this discussion today. We certainly need to pull them in at some point, but like we need to limit the discussion. So, and speaking of which, I want to kind of orient our discussion as we move forward before we get too deep into, you know, how this could work. I have some orientation slides that I want to review so that everyone's on the same page with where we're starting from. So for right now, if your question is to Tony about his presentation, then go ahead and keep your hand up. And if it's not to Tony about his presentation, then let me do a little orientation and then we can dive deeper into this discussion. Jim, it looks like your hand is still up. You have a question for Tony?
Yeah, my first question was, how do I raise my hand? But I figured out that by raising my hand, then the symbol shows up. So that was kind of,
Magic.
that must be AI at work. So I'm impressed. I'm also impressed with Tony's presentation, and the committee clearly has a good grasp of the stuff I've been living with for 30 years. I just wanted to point out a kind of a twist, a high that we have here in Maryland under a global budgeting system, and that I've experienced living in Germany. And that is a sort of a capped fee for service. And what happens in both systems is they project a certain volume. And if the volume of the particular service exceeds their projections, then the payment decreases. So they
Yeah.
stay
That's
with the
interesting.
budget. Yeah.
Yeah, that's really interesting.
Twist.
And just to clarify, that's in the hospital setting, correct?
In Maryland, it's the hospital setting. In Germany, it's the primary care setting.
Oof. Okay, let's Isabel, if I can request that you back up in the slides to the first reference slide. So it's slide number 9, I think. Right after the slide that says scope. Yes, perfect. Okay. So before we dive deeper into how this could work, I want to orient everyone to what we're working with. ORS 751 is the legislation that created the Universal Health Plan Governance Board. This is what the legislature is asking us to do. And we wanted to pull this out and highlight it because it's really worth going through these points and making sure we have to do this that's on this slide. If this committee and certainly the board and the other committees have additional ideas or alternative ideas that they think would work better than what's outlined here, we can certainly propose those in addition to what's here. But this is what the legislature has asked us to come up with, and we just have to figure out how the system would work within these constraints. So they've asked us to come up with a single payer healthcare financing system, meaning a universal system used by the state to pay the cost of healthcare services. And in that system, these 4 conditions apply. Institutional providers, that means hospitals, are paid directly for healthcare services or goods by the state or paid by an administrator that does not bear risk in contracting with the state. So this is the accountable service organization, that the ASO that Tony was talking about, that type of model. The second one is that institutional providers, again, that means hospitals, are paid with global budgets that separate capital budgets, establish the regional planning and operational budgets. The third is that group practices, these are clinicians now, are paid directly for healthcare services or goods by the state, by an administrator that does not bear risk in contracting with the state, by the employer of the group practice, or by an institutional provider. So they could be employed by a hospital. And then the fourth condition is that individual, oh, gee whiz, I just messed up my screen, sorry. Where'd it go? Okay, individual healthcare providers are paid directly for healthcare services or goods. I'm trying to move because there's something blocking me. By their employers, by an administrator that does not bear risk in contracting with the state or institutional provider, or by a group practice. So this kind of lays out how hospitals and providers are meant to be paid, so that they could contract directly with the state. If we had regional entities that did not bear risk, providers could be paid by them. They could, individual clinicians could be paid as employees of the hospital, as many are now. Or by their employers. So, whoever owns the practice could pay their providers that way. So this kind of gives the outline of how providers are meant to be paid. So it would really upend the current system. As you can tell by this, the thing that is not in here is third parties that bear risk, that is insurance companies. So this system would effectively eliminate private insurance companies, and all risk would be ultimately borne by the state as the sole risk-bearing entity. Okay, and then I want to show you one more slide. Next slide from this. So this is not from the legislation. This board, as many of you know, was preceded by a joint task force on universal health care. And they did a tremendous amount of work over multiple years to sort of work through some of the details about what this plan could look like. We don't have to follow their recommendations, but they really did put a lot of time and expertise and consultant work into this, and it's really worth our consideration to know what they came up with and to either build on it or adjust it or accept it as they've written it. So the task force recommendations really in our conversation focusing on regional entities, the Universal Health Plan and its board will operate in partnership with a network of regional entities on provider reimbursement. These entities are responsible for convening and collaborating with stakeholders in each region, ensuring that the plan is responsive to the unique needs of the wide array of communities across the state. And then the regional entities will advise with relation to coordination and delivery of care in each region, which may include advising on budgets, reimbursement, and capital spending for providers in the region. So those are kind of two pieces of information that I wanted us to have for reference before we dive in as a starting point. And again, we need to come up with something that meets these criteria. We can come up with alternatives if we think something different would work better. And with that, yeah, anybody who has comments or questions about this, turning the floor over for discussion.
Eve has her hand up in case you can't see it.
So just a quick clarification. I'm not seeing rates of reimbursement in this list. So did the task force envision that rates would be standardized across the state or negotiated by the state, or that the regional entity would be responsible for rate negotiation and kind of figuring out how the global budget for their region was allocated amongst the providers?
Yeah, the latter. So the region, one idea with the regional entities would be that we know that care costs different amounts in different regions of the state for all kinds of reasons. And so rates would be adjusted based on risks in the population. So health risks, like how complicated your patient population is, and on geographic area. Those are both mentioned. Yeah. So yeah, there would be adjustments to the rate of pay by region on those two factors.
Oh,
Jim?
I'm watching the symbol here.
That you're serious. That really does work. That's awesome.
So I'm a little bit confused by the use of the word rates. And I think when I think of a state system, I don't think in terms of rates. And I'm confused how you mean rates, because who's billing who for what rate?
Well, again, this is what we're trying to dig into. So we're open to suggestions on this. But one idea is, a regional entity would say, look, we have this many people who live in our region. The regional entities would be geographically defined. And we have this many people, we have this many primary care clinics, we have this many hospitals, this many specialists, and the risk level in terms of high needs patients, is this. And so we are requesting this. So they would get a regional budget that would be adjusted, the rate of their regional amount. For instance, if it was a population-based payment, they would get an adjustment based on risk and based on the region of the country. Now, the whole thing, all of the regions added together have to even out. So the negotiation would be between each regional entity and the state, but then among all the regional entities, because we have to, it's a zero-sum game, right? So we all have to stay within a certain state level budget. So if there was a state budget at the top, and all the regions get paid from that, then it all has to add up so that we come in under that number. But you could advocate or negotiate for higher rates than other regions based on your geographic location or based on the risks of your population.
Okay.
Tony?
Yeah, I think great question, Jim, as far as regarding rates, right? And I think that what comes into this conversation oftentimes is the history of where we're at, you know, whether it's a Medicaid rate, a Medicare rate, Medicare Advantage rate, commercial plan rate. And, you know, historically, if we put those in different buckets of thinking, you know, Medicaid pays 60 cents on the dollar, you know, Medicare, you know, close to like 90 cents, you know, variance on, you know, people's definitions of this, and then commercial anywhere $1.30 to, you know, $1.60, right? You know, I think that one of our conversations subcommittee is thinking about all this is that when we come down to that, is that in essence, in what 770 looked at is trying to equalize that. Right. And making sure that all patients, right, whether you're the marginally low income individuals that are going to lose out on Medicaid when they lose it in the coming years, versus a commercial, you know, patient, that this is where the question of equity comes in our endeavor here, is trying to make sure that everybody has equitable access to healthcare, and then it's paid at the same rate, and that we're not leaving people out on the margins. So, you know, I think that this is really a big focus. Where I'm involved in this work is that, you know, rural residents wouldn't be left in the lurch, as well as those of our colleagues in more metropolitan and those of BIPOC communities too. You know, I foresee, you know, this idea of a regional entity, of having existing spending, right? And look at, you know, current levels of spending and thinking about, well, we have that bucket of money in the global budget, and let's just say, it was the Eugene area, right? And having that bucket of money, then having that entity. And then I think our endeavor next is to look at, are people paid via capitated model for all primary care? Are they paid at fee for service? And then we have an ASO with it. I think that those are kind of our next steps in looking at how we do that. And looking at what we set up as our principles is perhaps identifying a general construct of how to do that, but then leave some space and recommendations how a regional entity could be innovative in trial of different structures to what would work best for them locally and regionally, right? And how they would do payment, how would they promote best practices. And so yeah, that's what I'm really excited about in our future discussion here.
Yeah, thanks, Tony. That's a really good point. So, Jim, back to your question about rates. Yeah, so Tony's absolutely right. So right now, if you have a given clinic in a given location and they see people for diabetes management, let's say, and so if you get your health insurance through Medicare and you have an office visit for diabetes management, making up numbers, Medicare would pay $100 to that provider for that visit. And Medicare, you know, they set their rates federally, and, you know, it's not going to budge. So that's going to be $100. If you have another patient that comes to that same clinic, sees that same clinician for diabetes management, but they come in with Medicaid as their insurer, the payment is going to be a lot less than $100, anywhere from $65 to $80, somewhere around there, that they would get paid less than the clinician would get paid less to take care of that Medicaid patient, even though it's the same diagnosis, the same care. And then similarly, if somebody walked in with a commercial plan, Moda or United or whatever, it would be more than 100. Again, making up numbers, maybe they would pay $140 for that same visit. And so the providers have an incentive then to limit the number of Medicaid patients that they care for, because they get paid less to do the same thing for commercial payments. So under Universal Health Plan, the rate of payment for a diabetes management system would be set. And one idea is we would use reference pricing, meaning we would pay clinicians for the care the same, regardless of who was getting that care. Everybody has like the same insurance under this plan. And so everybody would get the same, and it would be some percentage of Medicare. We don't have any authority or ability to regulate Medicare rates, but we could say, you know, whatever Medicare pays, you know, or the Oregon Universal Health Plan will pay, again, making up numbers, 130% of what Medicare pays. That means that no matter who you are, that's what that clinician would get paid. So it's sort of a win-win, you know, that would increase access to people who historically haven't gotten care because they have Medicaid, which pays lower rates. but it would be a real hit to those who, for those practices that were primarily based in commercial players. So you would have a universal rate for services. Everybody gets paid the same, and it would be reference price based on something of Medicare. So that's the kind of ideas that we talk about. But if it's $100 in city X for that Medicare visit, then in some other area, because of geographic reasons or because of risk areas, that whole scenario may play out differently, and their rates may be Medicare getting $110 instead of 100, right? So the rate that that clinician gets paid for that care would vary by region and by risk level of the region. So so those are the numbers that we're talking about, could be adjusted. Looks like Gabe, you have your hand up.
Really appreciate this discussion about health equity and Tony and other people's sort of motivation for this work, in part to address some of the current inequity that we have, and what I would perhaps cynically call sort of cherry picking. There's a lot of gaming going on, and yes, my understanding here too is that we could pursue local health equity, right? Within your region, the rate for whatever thing is going to be the same, where everyone has the same insurance, right? So you would have localized regional health equity, and there might be cost or payment variance depending on region and some of those factors. I mean, I wonder, as I look at this and the regional entities that the task force originally laid out, and I think about our current system in Oregon, I wonder, it seems to me that we perhaps have sort of a precursor for these regional entities already, as the current CCOs that are sort of regionally based and do have the freedom to get innovative with how they want to provide resources to local providers and organizations to address the care needs of their population. I wonder, I mean, are other people who are looking at this? Are they? I mean, I don't. There may be some political sort of hesitance about directly migrating the CCOs into being these regional entities, but I wonder if other people recognize or seeing this and thinking that that's one potential kind of model here.
Yeah, absolutely. That has come up a number of times. A couple of differences is that obviously CCOs are risk bearing, and the regional entities as defined here would be non-risk bearing. That's a big leap for them. The CCOs also have a couple of features to them that we might want to consider differently. One is that there was no requirement that they be nonprofit. And I believe right now there's one for-profit CCO in the market. And then a number of the CCOs overlap, and they share the same region. There's multiple CCOs in several regions. And the idea there is competition, but under a universal health plan, that competition wouldn't be necessary, right? There wouldn't be established networks of providers where you could, be with, Providence versus Moda or whatever in a different region. So the overlapping, the for-profit status, the number of CCOs, there are a lot of them. And so what is an ideal number of regional entities is another thing to consider. But I think if we suddenly said, yes, you're the new regional entities, but by the way, you can no longer bear risk, I think that would change the equation for most of them. I think many of them were formerly Medicaid managed care organizations. And so they got into it from an insurance company perspective. So, but yes, that certainly has come up, and, thinking about what we've learned from the CCO model in terms of how we would build these entities. I'm not sure who was next. Somebody else might want to facilitate questions, because I'm not sure. I see some hands.
I would say that Eve was next, then Angela.
Thanks. Just something to put a pin in, and I don't know that this committee has to come up with an answer to this question, but maybe some guidance around how the question would be answered, and that is, how are we risk adjusting? In my experience, the providers who are better at applying codes have the sicker patients.
Right.
And
right.
and even now I'm in a capitated model in my primary care clinic. if I don't bill for every encounter, including my nurse visits, because a doc didn't actually have to see that patient, we're just doing a blood pressure follow-up, I have to bill for that. Otherwise, I don't have the encounter, which demonstrates the acuity of my population, right? So all of this adds administrative burden to healthcare in order to prove that we're taking care of patients who are as sick as our neighbors. And I just wonder how much of this is really a game versus how much of this is honestly that we have populations that vary dramatically in how sick they are. And I don't know the answer to that question, but as we think about reducing administrative burden, I think that's a piece we have to look at.
It's gamesmanship, and it contributes to burnout amongst the clinicians too. Sorry.
I agree. I totally agree. I've experienced that too. Eve, would you suggest not risk adjusting and just adjusting based on, you know, past payments? Or have you seen a model where risk adjustment is done in a way that doesn't encourage the gaming?
You know, this is one of those situations where I can clearly articulate the problem, but I don't know what the right answer is, right?
Yeah.
And I think there are a lot of really smart people out there who could probably come up with a solution. It's just every provider group I have worked in has believed that they have the sickest patient population.
Yeah.
And so how do we really understand that? And I see other hands, maybe
Yeah.
those who are smarter at this than me will have a better answer.
Is it?
Angela, you're up.
Yeah. Go ahead.
Yeah, I agree with a lot of people's, I think where there are incentives, people will game them, right? I think that is the struggle, right? Whether it's patients in a capitated model or whether it's fee for service. You're either driving volume in one way, or you're like in the other model, you're adding more patients to a provider's panel, right? And that is stress and burnout too, right? So how do you create these balances so that that doesn't happen? I think something that I did see in the Making Care Primary model for risk adjustment, there was a certain amount of payment for HCC coding, but you also, if folks were in the low income subsidy program through Medicare, then you automatically got the highest risk adjustment payment for that. So some sort of proxy to, you know, that could be a way to deal with that issue. I also think particularly in Oregon's alternative payment and advanced care model, the way capitation is done is based on historical utilization. So saying, okay, this group of patients, you know, saw a provider, you know, 4 times in the past year, and you're kind of looking at that across a total population. And then, you know, that's how you're setting your capitation model, which I think is helpful when it comes to the MyChart messages, all the different types of visits, and the expansion of the care team too, because, you know, the rest of the care team isn't, for the most part, you're unable to bill for. So I think that's why, you know, in those cases, you know, when we're just straight up fee for service, then it's like, well, this isn't included in fee for service. That's not included in it. So that's where that struggle comes in too. So yeah, just a few comments, but perhaps there's a proxy.
The model you mentioned is called Making Care Primary.
Yeah, they dissolved it. So it's so that sucks. But I can send folks kind of, yeah, the risk adjustment part was like, okay, for HCC coding, you know, which, yeah, our providers are not great at. Yeah, it's more administrative burden. But the nice piece was that the highest risk adjustment could also be attained by folks participating in the low income subsidy program through Medicare. So saying the folks who qualify for that. And they also looked at a geographic area deprivation index. So that was another piece, like saying folks that if you're just in this geographic area, then you also, you know, you're also getting more money.
That's awesome. This looks a lot like the, I just pulled it up. It's a CMMS model. It looks a lot like the Oregon's primary care payment collaborative model that we talked about at our last meeting, but this looks like it's really worth digging into. Thanks for bringing it to our attention. We will dig into this.
Betsy had her hand up next.
Just a couple comments. One, I am curious because Medicare, does adjustments to payments for rurality and some things like that. And I think about other factors that might make it, that contribute to the expense of running a clinic, like what's the minimum wage where you are? What you need to pay someone to work the front desk? And that is different in a rural community than what it is. It's potentially different. I won't say it definitionally is, but that may be different because literally the state minimum wage is different in urban areas than it is elsewhere. And that may not be anything. What that led me to think about is the fact that we make payment for healthcare services do a lot of work in terms of incenting people to practice where they're needed, in terms of encouraging people to get care that they otherwise might not pursue, in terms of, the models that we currently have been doing that are innovative have had more aggressive, assertive, not aggressive, care management and care coordination. And one of the things I think we'll need to be careful to control for is in a situation, imagine that it's the first month of implementation here, and I'm still going to the clinic I go to right now that mostly sees commercially insured patients. They should not get, they don't need to do as much care coordination across their whole patient population as a clinic that mostly sees people who are currently insured by Medicaid. And so I think we'll have to adjust for that, unless we're also going to try to, in one fell swoop, redistribute patient attribution and assign them to clinics, and not let them move. I want to be careful. We'll need to be careful both on the side of protecting the clinics that are already doing higher intensity, more costly care, and therefore are getting reimbursed for that, even though through non-claims payment, and wanting to be sure, we'll need to be sure that whatever rate setting system we put in place also considers what else we're doing, what other factors are happening in the state. I often think of an example of a clinic that I know where when the state began its behavioral health incentive program and that provided additional payments to clinics that were behavioral health homes, a lot of they lost some of their behavioral health staff because they could make more money at the clinic across the street. Right. That was a really good example of right idea, bad implementation that actually ended up reducing access to care rather than expanding it or just moving the access across the street. So, yeah.
So Betsy, I think those are really fabulous points. Your first point about like how, care in different areas is different based on things like the minimum wage in the area. That's a really great example of how rates would differ by geography, right? Like just based on where it is, there are going to be costs that differ. So that's a really great example of that. And then to the rest of your points, it seems like, Isabel, if we can pull the slides up over to the OHA slide that we haven't gotten to yet, I think slide 21, the Oregon. So this is, we stole the slides, borrowed them from, this is from our last month's presentation when Claire Pierce-Robo came in and talked to us about this. This was sort of new to me. I've been out of the primary care world for a few years here. The primary care payment reform collaborative work that has been going on in Oregon for quite a while. I was really impressed with this. And I wonder if, Betsy, if this model gets at what you're talking about. Go to the next slide there. This was a collaborative created in 2015 to increase investment in primary care, move more to value-based payments and align payments. And then if you go to the next slide, this model that they've been working on, and I understand this is a voluntary collaborative, so I have all kinds of questions. We're getting more detail from Claire and her team coming up soon, but I have all kinds of questions about who's participating and what their experience has been. But the idea with the payment model is that the primary care payment model would include prospective population-based payments that cover the vast majority of services that are delivered. And then you could do fee-for-service payments for all other covered services. And then there'd be infrastructure payments that include base payment tied to PCPCH tier. So the patient-centered primary care home model, which has been really successful in Oregon, you get, and that goes to your point about coordination of care. If you're doing more coordination and you reach that higher tier of PCPCH, you'd get a higher infrastructure payment. So the payment that you get in this third bucket would depend on which tier of PCPCH you were in. And then you get additional payments for specific high value services, and then performance-based incentive payments. I thought this kind of captured a lot of what the concerns were about how primary care is paid. And I am hoping to dig way more into this and see if this is something that this committee would be interested in proposing. I wonder if anybody in this room, including you, Betsy, have experience with this collaborative model, no practices that are participating. Is this kind of what you're talking about?
It is, and I do. I've been involved in the collaborative for several years now, though I was not a founding member. OAFP was, but not me personally. I think this is some of the best work that the collaborative did, and it didn't get very far. As far as I know, there is one OEB payer who has adopted a model that's based on this, and it's MODA. And I think if this were the backbone of a single payer system, that would be a different situation than we're seeing right now in terms of the difficulty of getting clinics to sign on to this kind of model and insurers to offer it and employers to buy it, right? I mean, that's another piece of this that, right now these innovations are all dependent upon someone demanding them. And for the most part, what employers tell me is people want access to specialists. They don't care so much about the primary care. And so part of our work is I completely agree that we should be centering primary care in this work. And we should always bear in the back of our minds what it's going to take to sell that to the public, because we're going to need to bring along a lot of people who don't think about this stuff.
Tony, you have your hand up. Why don't you jump in and then we can do this more.
Yeah. So I'll just jump actually with this. I have a couple of things to go back to, but largely CCOs, a lot of primary care networks have adopted this. So what Betsy was referring to as far as in the commercial sector, there really hasn't been a lot of buy-in. So I just want to clarify that point is actually a great adoption of this has been in the Medicaid market with that. But it has been more restrictive in value-based payment because in the commercial sector has not supported that as robustly as CCOs have really supported the coordinated care model with this. These aspects, so if we go back to like the president of giving, has all the flavors of everything we were kind of talking about. So it has a capitated model, which is your prospective population-based payments. And then it has for more specific like procedural care, things that are above like immunizations, your fee-for-service payment for that. And then the beauty of the Primary Care Payment Reform Collaborative was to, over the last decade, build up more infrastructure. So what that came is, so for instance, like my clinic, for us to help get more integrated behavioral health, to support more nutrition counseling, more handoff methods with that. And then we do just a boatload of work on performance-based incentive from population health. And I mentioned these a little bit as far as we have our CCO metrics, OHP metrics that we work, but then we have this litany of all these different payers that we're 31 flavors, and there's some overlap, there's not that overlap. And that in essence is why if we had a single system, then we could agree on a certain structure. Like I wouldn't have Care Oregon's hemoglobin A1C set at 31%, Pacific Source is set at 29%, all these different things. And that's a bit going back to Gabe's point of some of the frustrations, the redundancies that we all have to do. And I did want to go back to that point, not to skew too much, but just having simplicity is our goal, right? If we can move towards, thinking regionally, maybe a region has some of these pieces and they get to distinguish a bit of those is really helpful. I think that's our question at hand when we're thinking of these. I think there is a lot of merit to these. I'll just say as a clinic, it gives us a prospective budget, right, to have a per member per month. And that brings a lot of solvency for clinics to say, hey, I'm anticipating these costs. I know I can expect that amount coming to you. And then to Betsy's point, I wanted to follow up on, the concern. So in a community health clinic, yeah, I'm very concerned about the risk of changes in payment. And, I'll just say that, the social deprivation index for my community is pretty high, right? If we flip to this system and I'm not on 30% uninsured and 70% isn't paid at the Medicaid rate, right? Well, my clinic just had a huge boost, right? And creates, again, that equity conversation of supporting that. We do need to be very thoughtful to that. And I think the assignment of patients, I'm very curious to that question. Would a lot of my patients move over to other clinics? Would they, would more patients, different patients come to our clinic? Would more commercial patients, well, not in the future, but I would foresee some movement, but we would be able to foresee, assignment. And I think that's a question that we're going to need to think in this system is how often can you change, for assignment and thinking through that. That is an outstanding question with regard to this.
Can someone say more about why this model hasn't been taken up by commercial? What is the reason why people don't want to participate in this, either payers or clinics? I want to make sure I understand.
I can give you what I hear, and it is that the prospective payments, if they're offered, are laughably small. And often they come with the plan, or the value-based payment contract might be based on this, but might also have downside risk, which is not tenable for many clinics. The incentive payments and the quality metrics required can be very difficult to comply with. Some of my clinics tell me that they are currently reporting on 70 to 75 different metrics across their various contracts. And that's just not it. To Tony, I really appreciate the solid numbers you gave to that, Tony. One contract wants 29%, one wants 31%. And, what private clinics, such as there are, independent clinics don't have is the capacity to have the sophisticated analytics to assess whether or not this contract is going to be a good deal for them, right? To know enough about their experience and their finances retrospectively to be able to understand whether or not this is going to result in sustainability for them. That's what I hear from the clinic side. I really do think that part of the problem is the lack of demand on the employer side. And that's part of why in my other seats where I sit, I'm trying to get employers engaged in this work, because they can't afford for healthcare costs to continue to climb either.
So when you say employers, you're talking about the large employers that are paying for any employer that's paying for health insurance. If the employer demanded that this model,
primary care centered plan for my employees that has very few barriers to access to primary care, and that is my priority rather than a wide open network of specialists. But that is almost never what you see advertised during open enrollment. It's we have the broadest network, no referral needed to get to the cardiologist. That is what is marketed. That is what the public sees as a high value plan.
Got it. Yep. I got it. Yep. I've seen that too. There's been a lot of advertisements now for you don't need a referral now to see a specialist. And
exactly,
it's kind of shocking going in that direction. Is that really where we want to go?
What that billboard wouldn't tell you is that your out-of-pocket maximum is like $15,000 for your family, and you're going to be dipping deeply into that to see that cardiologist you didn't need a referral for. But as long as you can see them, that's a very compelling marketing message.
Yeah. Okay. Any other comments or thoughts? Now might be a good time for a break, but if somebody wants to jump in with comment or thought on this topic.
I guess the one thing I would add to that discussion, Betsy, I really appreciate the sort of perspective on what is marketed during open enrollment, and I'm trying to resolve that with the other thing that I experience all the time, which is I see a lot of patients who don't have access to primary care, like a lot of closed panels and wait times to get a new appointment. I just finally, as a primary care doc, I finally established care with a PCP of my own a few months ago, and I had to, I contacted the clinic and got it scheduled, 5 months. I just had to wait 5 or 6 months, and I could get in and have a PCP of mine. And I hear that from the patients who are on my panel, how grateful they are to have me as a PCP. I think more of them are recognizing that they're lucky because they hear from their neighbors or family members that it's hard to get a PCP nowadays. That Oregon has a real sort of primary care access challenge. So how to rectify those two things and really capitalize on the value that primary care does offer to people, and in terms of the specialist access, I get a lot of patients who come to me and say, I want a referral to dermatology, right? And actually the vast majority of the time we can manage their dermatologic concerns in the clinic.
Right.
Obviously you guys know plenty of other examples like that.
Hey, Helen, can I add just one other thing in
Yes.
thinking about Gabe's prior comment regarding acuity coding and the inflation that we've seen with that, and the burden that is producing on providers. I just see that is again, it's been said that is a gaming tool. And we continue to see it, and it came out of, the sector of Medicare Advantage is where it was started, and now it's just seeping into all aspects. And, I just think that there could be in this construct a different way of evaluating risk. And that is a billing tool that we've just adopted as the way of saying risk. But, a number of things are also, as Angela mentioned, factors into people's true risk and the social determinants of health. Again, I think our efforts here afford an opportunity for a different way to assess that. I think we could be innovative and creative if we move towards a system that we're designing here to evaluate that in a different format that's not going to drive the workforce crazy, and permit some prohibitions of gaming of the system, where the system that can have more coders, can use AI to do it, we could be more preventative of that.
Yeah. Okay, great. Let's pause here and take a break. It's about 2:30. We can come back at 2:40 and continue the discussion. Okay, everybody, welcome back. On the agenda, it looks like, there's we could be moving on to another topic, but I want to spend a little bit more time on this because I think what I'd like for this group to do is do a little bit of imagining with me and see if we can sketch out what this could look like. So understanding the problems with the systems as it currently is because of all the different payers and all the different strategies of payment. If we could just imagine for a moment that that you were in charge of a regional entity, some region of the state, and you had a fixed budget to spend for the year on all the healthcare needs in that state, how would you pay primary care and behavioral health care? So what is the model that we think has the best promise for paying outpatient clinicians? So again, we're not talking about hospitals. We can leave out specialists for the time being. But if you could determine how primary care, for instance, or behavioral health care, or both, were paid, what would it look like? How would you determine how to pay them? What proportion of your total annual healthcare budget would be spent on primary care? And how would that look like? If we can just sort of think through a little bit about, is this model of the primary care collaborative, could that work on a regional level? If it was the only model out there, like, could you implement that across a whole community? If so, what would that look like? If not, what are the alternatives to that? So I don't know if anyone has ideas or wants to get us started on that.
Hello, I have a question. When you say behavioral health,
Yeah.
because within behavioral health, you have psychiatrists, you have psychologists, you have licensed counselors, you have, LCSWs, and all of those different disciplines or categories are reimbursed currently differently, similar to how a specialist would be reimbursed differently from a PCP.
Right.
So when you say, so I think behavioral health is not singular, right? In terms of when you think about a payment model,
Right.
similar to, when you think about PCP versus a specialist. There's specialists within behavioral health.
Yes, I agree.
So something to think about.
Right.
Yeah.
Right. So how could it work that we would so similar to I don't know what to call it, other than non-behavioral health, like regular physical health care. There's sort of a ground level of services that should be very easily accessible by everyone in the population, all the routine mental health and substance use treatment versus the specialty level care. So, basic counseling and treatment for depression, anxiety, and, treatment for alcoholism, and,
And within that, you have to add medication management.
Of course. Yeah. So there's like this ground level floor of like what is available to everyone, sort of like primary care in behavioral health. And then there's the higher levels of specialty care or extra services that certain populations will need, or more care coordination. But the question is, like, what would work? Like, how would you pay for it? Like, how would you structure it if you were in charge of this regional entity? Tony, I see your hand.
I don't have for or against right now, and I'm really interested in our further investigation a bit more. But as far as perhaps a look is that you take existing spending, which I think we need to define further, of what do we have in primary care at this point. Our goal as a state, we've set into statute, is to reach 12%. I think there's some criticisms that we're not reaching 12% because we don't have adequate definitions to exactly what that does incorporate. And it leads from Dr. Hemming's comments to what is included in that. And so there are some models for us where behavioral health is in my clinic. I have a mental health prescriber that's an ARNP. I have 3 behavioral health counselors, that one is a clinical social worker, one is a clinical psychologist, right? So there are some definitions that are challenging. I think you could start with some broad brushstrokes and say, well, maybe in my perfect world, I'm selfish on this, but coming from primary care, I think in most developed nations that have done healthcare very well, they actually move the mark to 15% for primary care spending, right? Divide that up into a regional entity and a global budget. And then, I think this is what still remains to be seen, is like, I'm not so certain that I have the best I think there are merits to some of these hybridization in payment models, a capitated model with fee for service on top. That's where, a lot of healthcare has moved in the last decade. But I am very curious about this model in Connecticut to look at, is it just simplicity to do a fee for service? And what are the elements that are really driving home cost savings and actually good care? And the elements of an ASO where it is supported coordination of care and promotion of patient-centered medical homes. So if I were just to set it up today as a straw proposal, is set it at 15% primary care, divvy that up as regional entities and globally to regional, and then try a model that I think would probably mirror per member per month with fee for service, and that hybrid model is what I'm leaning towards. But again, I'm really interested in Connecticut.
Jim?
At the beginning of this, Tony made some really good remarks that I think are worth latching on to. One is the concept of simplicity. And as I'm thinking about this, one of the challenges that we face in trying to imagine a new system is, to what extent are we constrained by the status quo in our thinking, and to what extent can we find solutions in the status quo? And one place to look might be staff model HMOs. And how do they manage primary care? They mostly pay their physicians salaries, and they obviously have presumably some mechanism for managing sort of the outcomes of those primary care services. But to answer the question that you posed at the beginning of this discussion, what I would imagine is, when you talk about fee for service, there's two pieces to that. One is the fee and the other is the service. And how granular is the service? And to what extent can we bundle services so that we don't get overly granular in our reimbursement model? And you might think of a certain set of services that would be included in some kind of reimbursement model for, say, a clinic.
Yeah, like diabetes care for a year, kind
Yeah,
of,
exactly.
as opposed to every diabetic visit.
Right. Yeah, I guess that's kind of the main thing that I wanted to put out there.
Yeah, that's a really interesting idea. Eve?
I think the push and pull I am experiencing is Tony got to earlier in the conversation. I think probably the most appropriate, least cost model for someone like me in primary care is fee for service. I am a relatively healthy person. I have high level of health literacy. I just need to show up. The doctor generally spends 5 minutes in the room with me, gives me a little bit of information, and I run with it. A capitated payment for somebody like me becomes a windfall for whoever has me as a patient. But then there are a number of individuals who need a lot more from a case management, traditional health worker perspective, and ongoing nurse visits or pharmacist visits. So really, rather than acuity necessarily, because I think of acuity as like, how sick are you? And granted, someone who's really, really sick is going to need more intensive care as well. But complexity is more than just that, like your health acuity. And so capitation works better in that model, I think, by far, because you can bring in the additional supports that are needed. And that is the cheaper model with a more complex population. And I don't know that we will be successful in a one-size-fits-all approach. If we do capitation for everybody, rather than competing for payer type, providers are just going to be competing for the healthiest patients. And we talked about gaming the system. No matter how you slice it, there's a way to game the system. So how do you assess truly? Maybe the regional entity could assist with this, actually, truly doing an assessment of the needs of the individuals within the region and assigning them, maybe there's 5 providers who are a tier 5 PCPCH. And they say you can pick one of these 5 providers, or you're assigned to one of these 5 providers if you're at this level. But then moving down, maybe folks get assigned to different provider groups where you're doing a better job of matching to the structure. But then it's complicated. So I don't know. I don't know how to do this simply and well. And the more complicated it gets, it could be argued that that's not doing it well too.
So if they're geographically defined regional entities, though, could you, and you were the only one, I mean, obviously there's only one, they can't overlap. And so you can't really compete for patients, can you? Because it's just whoever lives in that region is your patient, right? And so your responsibility is to take care of everybody who lives within that geographic boundary, period, right?
I'm more talking about the individual providers. So I assume that patients are still going to have some degree of choice. And the providers will still be advertising, trying to get the best patient mix to come to them based on whatever incentives are in the new system.
I see. So, but what could you, so I think that's a really important point. And like, what would you do to mitigate that in terms of like the primary care? Let's go with Tony's suggestion of 15%. We've got a set regional budget and 15% of that is dedicated to primary care. And it's a zero-sum game, right? And so maybe that 15% has to be divided among the primary care docs, right? And so if you're taking care of healthier patients, you're just going to get a smaller piece of that 15%, and the people taking care of the more complicated ones get a bigger piece, right? They have to, how would you do it so that primary care worked as a unit within your region as opposed to competing with each other? Is there a way to do that?
I'm curious about everyone's thoughts. I don't know how to get out of an environment of competition short of assignment, like we do in Medicaid. You get assigned to a medical home and you have an option to say, I don't like my provider, I want to go somewhere else. And then you get assigned to another provider. I don't know that the broad populace would adjust well to that type of model. I don't know. I'm surmising that. I do. Today we use income as a proxy. So FQHCs, PCPCHs are, the intent really is to wrap around a population that is perceived as more complex, and often it's true because of income level and some of the social circumstances that go along with that. Do we maintain that as a proxy around if you still qualify for Medicaid, you maybe qualify for a higher reimbursement rate? I don't know. We don't take care of a lot of the Medicare population in my FQ, so I can't speak as well to the Medicare, the considerations, how you would do that in Medicare. I'm sure it's more than income. But that's one way that we could maybe utilize things as they exist today to help inform a model of who needs a level of higher reimbursement rate.
Yeah, Tony.
As I think about delivery on quality, let's talk about outcome. So, you know, in thinking of a patient population, you have Eve who's very healthy. You have another individual that's on dialysis, multi-organ failure, multiple medical complications. We want to incentivize clinics to continue to increase contact with that patient. And ultimately what we want is we want to keep them out of a hospital and keep them out of an ER. And that's where a great deal of cost saving comes from. That is where you can do it a couple ways. Pay for performance, where you say you keep your rate of keeping people out of the hospital down, right?
Mm-hmm.
That's one construct that we use. We have used two-sided risk in contracting. The challenge with a lot of primary care is a lot of them can't do that, right?
Meaning
So
manage their own risk, like be risk bearing. Yeah.
Yeah. And actually, that's where I think
they can't do it for financial reasons, or for what reason?
I think administrative, really, right?
Both, right?
Yeah.
So if it depends on the entity, the size, right? So if you're a larger health system, then you can, right? But if you're, a practice of like 3 to 4 practitioners, if you have a NICU baby, or you have somebody that goes in the hospital for 2-3 months, and you're accountable for that, a lot of people don't buy into that because the risk of that is too great, right? So this has moved us towards consolidation, actually, a lot of practices, and a loss of more independent practices. So there's other things to think about with us developing a plan with that. I think the value in this hybrid model, it does, in the capitated model, promote attention. So my clinic, we run numbers every week looking at our ER visits. We look at our hospitalizations. We ensure that somebody, when they're coming out of the hospital, that we get an appointment within a few days. We're having contact with our ANs to do that. Do we do that because we're incentivized in a capitated model? I would say not necessarily. We're motivated actually in the sector of pay for performance, where if we're paying attention to that and we're keeping that. So that's a coordination tool to ensure quality. And that's kind of the distinction I think we're still making, is thinking about, do we develop a program that is incorporating financial risks and skin in the game, or is the merits of ensuring quality of the coordination of care, and maybe having a clinic that has, like, I wish we had more social workers. I wish we had more traditional health workers to do that body of work for the coordination of care.
Mm-hmm.
But a lot of clinics aren't incentivized that way because it's not set up that way. Part of the value in the patient-centered medical homes and the primary care payment reform collaborative was some of those infrastructure payments to build those up for clinics. And that's where that was done very well. Again, I'm very interested in Connecticut because they do the ASO model, where they're supporting more of that coordination care. And we know that a third of patients are the largest spending, about 80% of all healthcare dollars, right? And focusing on promotion of coordination care and the tools and the workforce that needs to target to get those people would probably be better served. At least my take on this issue. Again, I'm not so sold that the ACO models over the last 15 years have a very mixed review as far as having the risk bearing, right? And what I think we're constructing is consideration that when you have a management service organization, you have an insurer, that part of that is administrative waste.
Yeah.
Is it necessary to have that, right?
Yeah.
Is that rent seeking? Is that a valuable entity in the system? And I think that is in question here. And I think that moving towards simplicity of having one single entity that's at risk and delegating the role to the coordination of services is the ideal way to do that. How you pay individual regional entities, I would like us to see some leniency, but I see we're going to need to define this, because we're going to need to give this to actuaries to say, hey, here's how we're going to do it.
That's right.
Run the numbers on it.
That's right.
What does the numbers look like? Because then that says, when we come to benefits design, how much is in, how much is out, what's included, what do we need to do for tax revenue, and what is the dollars in that. So we are going to need to come to divinement, and maybe that's a consideration where we have two constructs, where we have like a fee for service and then promote coordination of care, and maybe another that would be a per member per month capitated model, that we could take something like making care primary, or a model like the patient-centered medical homes, like the CCOs do.
Yeah. Or more than two. So, I mean, I spent my 17 years in the federally qualified health center model, and did care that way, and then now I work for Northwest Permanente and am experiencing what it means to be in a model where the providers entirely bear the risk, and I love it. I think the practice is different, and the way that Northwest Perm functions in its relationship with Kaiser is phenomenal. And my work at HealthShare introduced me to some of the ways that Providence was moving toward that model and allowing their provider groups to bear more risk. And so my question is, maybe if within a region, if we could give primary care the option, if there are provider groups who are capable and willing to fully bear risk, we could have that as one option, that you would just be given an MOU set dollar amount for the year, go for it, do what you want with it, and they could entirely manage that on their own as a provider group. The second model would be, I think what Tony's referring to as a hybrid model, which is like the primary care reform collaborative model, where you'd get some prospective payments, you'd get, just a little bit of capitation, you'd get a little fee for service, some infrastructure support to build out. And that hybrid model would be based on your PCPCH tier. And then you'd have the option, if you wanted, if you were a small practice or an independent clinician, you could be fee for service if you wanted. And you could do any of those three options within the region. But the fact remains that it's still a zero-sum game, and we'd have to decide what portion of the pie belongs to primary care. And then the primary care groups in a given region would have to negotiate to stay within that, I would think. There's not an unlimited budget, right? And so there still would have to be some way of controlling costs at the region level and saying, we can't spend more than this, and here's what I mean, I'd love to see the numbers. I've never seen all numbers pulled out. It seems to me it should be more than 15% even going to primary care, if we're really going to do that kind of investment. But I don't know. I'd love to see how that all breaks out. But this is the amount that goes to hospitals. This is the amount that goes to ancillary services. This is the amount that goes to pharmaceuticals. Here's the amount for specialists. And then we're going to reserve this amount for primary care. But it would have to be negotiated among providers. But giving clinician groups and individual clinicians the option of those three, what do you think of that? Eve, yeah, you have your hand up.
I think any full risk model, if we're talking about more than just primary care risk, is going to have slow uptake amongst primary care providers. Primary care risk is much more reasonable.
Yeah, it would just be primary care. We're not talking about anything beyond that.
If we say 15%, and that's statewide for primary care, that's one thing. certainly a lot of our rural communities have very little access to specialty care and maybe no access to a hospital in their area. So their percentage is going to look a whole lot different.
Yeah.
Compared to the percentages in the urban areas, or maybe transport costs are higher in those regions to help get people to the urban areas where they can receive the care. So it's hard to set percentages even out in the abstract without having the local context, I think. We haven't talked about behavioral health yet. And I feel like some sort of a tiered model is important in behavioral health as well. I think fee for service has a tendency to work in, again, low acuity populations. With the individuals that we serve who have serious and persistent mental illness, they may be mandated into treatment. They have often lifelong disability. What is most important is a care team model, so that there's a prescriber, there's a set of therapists on that team, there's a set of case managers who are working with someone. That we have been advocating for years lends itself to a capitated model of reimbursement. But again, it's just the highest needs individuals who have the highest level of disability who really require that level of coordination and support.
I think, don't we do that with the CCBHCs? Capitate them? I think is anyone on here an expert in that? I feel like we already, yes, I agree with you and feel like we do that.
We have not become a CCBHC yet. I thought they were still pretty darn fee for service, but I may not have kept up.
Yeah, I'm not sure.
They,
okay.
Helen, they get paid like FQHCs and they have a wrap.
Oh, that's right. They have a wrap. That's right.
As opposed to the PCPCHs are getting, depending on what system they're in, they're getting this enhanced PM per member per month payment, which helps to pay for that team that and all those without having to do more widgets of doing more visits.
Yeah. Okay, go ahead, Eve. I didn't mean to interrupt. Go ahead.
No, I think that was just my point is, I think different payment structures for different kinds of patient populations would be warranted in behavioral health.
Betsy? Betsy, you're on mute if you have your hand up, but I don't. You're not on camera and you're on mute. Oh, she may have stepped away. Janine, I'd love for you to weigh in on this discussion of how you think we should optimally do it.
Well, I think it's interesting about the ASO in Connecticut. I'm not super familiar with it, but from, it is a managed fee for service approach, but they're outsourcing all that to 3 different plans that do everything. There are probably some counter arguments that they can deny care and that saves them money because the company is being paid not so much on risk, but on number of enrollees, a certain amount. And so if they're not approving referrals, etc., so there's issues in terms of that, of having that ASO. But some of the results, they've been doing it for quite some time. They did save a lot as a state on administration, and they also did save. They have been doing some improvements in their quality measures, etc., from the latest report out of the Connecticut entity. I know Anya, who's not able to join today, she is working to see if we can get you all connected with the Connecticut. She knows the former Medicaid director. So for maybe a potential future meeting. But I think, again, I being a kind of an advocate for the PCPCH model, I think the idea of not being paid, having some sort of payment that's not tied to per visit I agree that not all patients need a team, but in order for a clinic to manage and pay for people who can't bill, there needs to be some sort of payment arrangement that augments the fee for service or is instead of the fee for service, because that allows a team inside a PCPCH to pay for those additional people that aren't putting in a claim. So we have always promoted that getting people to pay something more for that team-based, patient-centered approach is what's going to sustain those clinics to continue to be able to perform that approach. And we know from the studies that Dr. Wallach did from PSU, we're saving $12 to $13 for every dollar you're spending in a PCPCH. So it just seems like there's got to be some way of trying to get away from the widgets that I have practiced in for 30 some years of just trying to crank out the patients, but being able to spend more time with the ones who need it and less the others, let my team work around me and help me do that is so invaluable in terms of transforming from what my early days of practice were like to what the current practice model can accomplish.
Do you think that the payment reform collaborative model of how they do it and base it on PCPCH tiers, do you think that would be a good way to adopt it sort of region wide? Like if there was.
You are talking to the person who wrote the bill that led to PCPCH. So I'm kind of a
right.
slanted viewpoint from my days in state government. But I think the reason we ever developed the PCH model was to use it across all payers. It's unfortunate it's not always as well adopted by certain payers, and the self-insured employers don't really get it. And it has been a challenge for take up on some of these models, of which Betsy could certainly give you more information about. But I think tying it to PCPCH would really follow in the traditions of the last 15 to 25 years of Oregon's efforts, and would get you, and as long as the payment is structured in a way that it gets you away from the widgets of fee for service.
Just to interrupt, Betsy was trying to unmute and she's struggling with that. I don't know if there's a button we need to hit.
That should be fixed now.
Yay! Thank you so much.
Sorry, Betsy.
No worries. I got off the audio and came in a different way. Yeah, I would echo Janine's comments, and at the risk of further complicating things, I am by no means an expert on appropriate percentages of primary care spend, but I will say that in the work that I've been doing in the last 6 to 8 months, talking, exploring how other states set their targets, exploring what the real world perception of primary care spend is. Fun fact, most consumers think we spend about 50% of healthcare on primary care. I'm not sure percentage is adequate in terms of a goal. And part of it goes back to the point that Gabe was making, that it took him 5 months to establish with a new PCP. However we structure this, we have to ensure that there is enough access and enough capacity for primary care in the system to actually deliver the amount of primary care we know is the right amount. Not to call any institution out, but Gabe works for OHSU, and OHSU does not have adequate primary care access for its own employees, much less for the community that it serves. And that's not particularly, I don't think, a strategic decision on their part, but it is a reflection of how the system evolves when the money is going to what is most lucrative rather than what is most beneficial for keeping people healthy. And so I feel as though payment isn't going to get us there. That's not enough of a regulatory framework to get the system that we want. And so in this redesign, I think it's not within the scope of this subcommittee, but I think there needs to be some attention paid to the market and who the providers are and what capacity they need to ensure in order to be able to participate in this new enterprise. But I would also say if I had to pick a number, it would definitely be higher than 12. And a lot goes into how you define what primary care is, who is delivering it, and where it is being delivered. So in my view, care delivered in an urgent care should not necessarily be considered primary care because it is not longitudinal. It is not the primary care home model. And it is emerging as the access of last resort or as of choice for many insurance companies and healthcare systems because it makes more money than primary care, but also it's easier to staff with folks who are more affordable, and you don't have to worry about care coordination and follow-up after someone's discharged from a hospital, all the things that Tony just said. So that's where we're headed right now, is more and more dependence on telemedicine and urgent care. And when we switch this system over, we have to make sure that what we're doing is going to actually ensure that there are enough clinicians to provide the care that we need.
Yeah, absolutely. Mimi, did you want to jump in?
I actually have a question for Janine, and it has to do with the size of a population for a PCPCH and what is a minimum amount, because I think I live in rural Oregon, right? And so there are some solo practitioners out and around here, and clearly they can't be in a fee-for-service model. Capitated model. So I'm wondering if when you've been looking at this all the time, kind of thinking about having these, two models, some primary care will be capitated, but of course to serve everyone in the state, we'll still need some, solo or small practice providers who may not fit in that model. So that was just my question.
Well, it's variable. It depends on what, if you look at the science of empanelment per provider, maybe it's anywhere, again, depends on the complexity of the population, but, be it 1,500 patients per provider. But, the PCPCH program does have small 1 to 2 provider practices that have been recognized. They may not be ever recognized at a tier 5, but they're recognized and getting a PMPM. So it is doable with a small team or teamlet, as well as with a larger team. So, the larger clinics are, Richmond, where we had social workers, we had nurses, we had a PharmD. That's not going to happen in a rural small area, but there are ways that they've worked with that and are able to be PCPCHs. So, but if you have a really sick population that a lot of the FQHCs are seeing, 1,500 per provider is too many patients, and they probably need closer to 900 or something. So it's variable. There's not exact science to it. And of course, many of these providers could probably weigh in here on the committee and their thoughts on that. But
thanks. And I was curious, with some of those smaller ones, is there a fee-for-service component as well? Or is it strictly capitated?
It just depends on the relationship they have with their insurers, right? But in this of a universal plan, you're going to have one payer. So there's probably going to spend less on billing 10 different plans and be able to spend more focused time on care, ideally, under a universal arrangement. But and there also are where these things are under a capitated type payment, and then these things are not procedures or so there's different ways to also structure how depending on what, again, different health plans contract differently with them on what is and isn't in it. But in this case, it'll be the one plan that sets the tone.
Thank you.
Anyone else have thoughts or questions? Tosh, we haven't heard from you today yet.
Yeah, sorry. I was on a work meeting.
Sorry.
Something talking about rural communities, something that I've also wanted to bring up, the IHS model, and they are very diverse and innovative in how they have caregivers assigned. So they use a lot of uh, pharmacists to run their anti-coag clinic, the diabetes clinic, hypertension clinic, and I think they're also moving towards iron deficiency clinic too. And that's something that also other healthcare systems in other cities, states utilize. Um, and the whole reason why they do that is to free up providers to look at other disease states and lower the burden on how much primary care has to visit and the number of patients that visit primary care. Is that something that we can consider in our universal health model to allow for some sort of service that we can encourage primary cares to coordinate services with pharmacy groups or even like the local pharmacy to provide XYZ services, and they can be incorporated in a payment model.
Yeah, do you know how it works in IHS? How are they paid?
So it's mostly fee for service, but the pharmacists have a collaborative practice agreement with the physicians because pharmacists cannot prescribe, right? So the lump sum of money goes to the provider and then it's distributed among. But IHS is the payer, so IHS manages it.
And then the provider groups pay the pharmacists to do this extra level of service?
Correct.
Yeah. I would think that that's the kind of setup. I mean, we do that quite a bit in primary care. We have anticoagulation pharmacists, we have diabetes pharmacists, and our pharmacists manage all of our warfarin usage. I haven't managed warfarin in years, so like there are, so I think there's a lot of different models whereby if the provider group has more control of the money and how they deem best to spend it, they could build out models where it's all nurse visits or where it's more virtual visits or pharmacists are involved in a bigger way. And those are the kind of individual solutions that come with capitation or infrastructure payments. And certainly happen in when the providers bear all the risk, then the providers can decide how they want to spend the money. So yeah, I think that model could be incorporated in any of these ideas. And if IHS does all fee for service, then obviously they're making it work with a fee for service model too. Tony?
Yeah, Taj just kind of gave me some thoughts and back to our principles that we were thinking of as a subcommittee. I'm thinking of this as being innovative and creative, and I've worked in IHS a little bit, and there's some really curious models there in working in a rural setting, in promoting it and incorporating community members, in the structure of they're in community and then they report up to a primary care doc in that region. But they're really the predominant care deliverer in the area and elevate where a patient needs to be seen. And it is on, they determine how frequently that takes place. And it's really a great model, particularly for a rural community that's geographically challenged across, such a landmass. But thinking kind of back to our work is, how do we set the stage for something of model development that would lend itself to explore those? I think it has a lot of merits to, meet the community and meet the community needs. Also save on money because you're paying in a different, for that difference in level of care and allocating it just a little differently. So I was kind of wondering, if I can be so bold as some asks in our next, thinking through this. I wonder how many practices are in a patient-centered medical home contractual agreement that's probably in the CCO sectors, but I'd be curious outside of that of looking at those, so we could look at some total numbers of patient or health centers or healthcare providers or health systems that are doing it. That I'd be curious how many are in the staff HMO. I think Kaiser is about 500 to 600,000 lives covered in the state, and looking at how we, and this is another principle of thinking about where we're at now. How do we transform things, but also maybe think about where we're at, and could we maintain the integrity of some of those so we do have buy-in in the system? I would be interested, again, mentioned our connection. If Anya has that connection to that medical director in Connecticut, it'd be phenomenal to hear more information. And then I'm just going to keep going, ask with Dr. Chi in looking at a presentation on Taiwan and how their payment structure and how they do fee for service, and how they've, most recently, a colleague actually went to go visit Taiwan and said that they are doing some changes to more capitated model in this hybrid incorporation. And then Mimi, you did mention that there is an ACO in Bend. I don't know if we have any connection, just
yeah, I can reach out to them.
That would be great.
Absolutely.
Yeah, those are all great ideas to continue the conversation. I'm guessing that, well, first of all, does anyone else have any thoughts or comments they want to share?
Hi, I'm sorry I can't raise my hand. I'm driving, so.
Sure, go ahead.
I have a little bit of a concern. We seem very focused on primary care, and I'm just concerned that we are leaving out. I don't know if we're going to get to behavioral health. I know we mentioned it briefly, and the specialties too. And I'm just kind of concerned that we're very focused on primary care, and I'm wondering, is the thought that are we going to require that all primary care become a medical home, which would include all the various specialties and including behavioral health? Because I'm just wondering why a lot of this conversation seems to center around primary care.
Yeah, that's my fault, Rosemary, because I asked the group to limit our discussion today to that. I started the conversation by saying that payment to providers is super complicated, and yes, all of those things need to be addressed, but that starting with primary care and figuring out a structure for paying primary care would be our first step, and then the rest of the scope could be tackled later. So yeah.
Okay, all right, thank you.
Yeah. Anyone else? So yes, so thank you, Tony, for that great list, because I think that'll launch us and we can continue to bring some more information back. But what I would encourage this group to do, next meeting in August, we will bring back some of those topics and kind of go through some of those ideas that Tony just mentioned. But in addition, I would ask all of you to really think about this question of, if you were in charge of a regional entity and were in charge of how primary care would be paid, what is a good way to structure that? How would you do it so that it meets the needs of the community, that it, accommodates practices that are really different levels in terms of care coordination? How would that work? We have a cool opportunity on this board to present a recommendation to the state legislature to say, here's how it could work. Here's what it could look like. Here's what like really good primary care payment and delivery could be, and we have to put something in front of people that they can get excited about and say, wow, that could be a model that really changes the game, right, in primary care and gets people more access and works on improving health equity and improves the state of care for our communities. So I'm excited about that opportunity to put forth an idea, but I need help coming up with that idea. So we can spend a lot of time, going over the problems in the system, but like what I'm really hoping for is generating some proposals next month about like what primary care payment could look like to really encourage excellent, high quality, easily accessible primary care that people love to practice in. So it's a big deal. So think about that, please. Talk to your colleagues, talk to your organizations, pitch some ideas, and like, let's try to put together a proposal, and we'll try to start tackling some recommendations at our next meeting. Any committee member reflections or feedback about how this meeting went? Any other ideas of topics we should talk about besides those Tony already raised? Feedback of any kind would be appreciated.
I'm sorry, Helen, because I was out of range for a little bit. Did you go over the quality slides, or did you decide?
Oh, I skipped them. We can, well,
if you want, we can just move on from there. Sorry, I just wanted to remind you.
Yeah, go ahead and put them up. Like, so this is, so, you know, I guess the other thing to think about sort of as we advance the discussion, and I think we'll get into this a little bit more in our August meeting, is how quality fits in, because you know, one of the reasons why we moved away from fee for service and toward other means of payments, one of the reasons is to try and address quality, to try and pay for quality instead of just paying for services. And so if we are going to look at different payment models, one of the key things we need to consider is how does the payment model incorporate addressing quality? How would we assess quality? How would it be integrated into payment versus dealt with separately? It's not the job of this committee to come up with quality metrics, but to think instead of how metrics or other assessments of quality could be used as part of it. So things like clinical guidelines are another way of addressing quality other than metrics. So compliance with, you know, various guidelines. We talked about this a little bit before, of setting standards, and then you know, that these are quality standards that we adhere to, and, you know, adherence to those earns more points or payment. Credentialing, and then value-based payment models. So thinking about all of those aspects of addressing quality as we think about quality improvement, as we talk about payment reform. Is there a second slide? Right. So yeah, so we kind of brought this up already, but how does the proposed payment model address quality? What does it incentivize? And then is there a decision-making body at the state level regarding adoption of measures? We do this at the CCO level with the Metrics and Scoring Committee. Would there be sort of a parallel process for this plan to address measures? And then should each region have the ability to have their own quality measures? So for instance, if there was a single set of metrics for the whole state, you know, let's say eight quality measures, and those change and get renewed and refreshed and retired. But there's a, you know, single set of metrics that everybody has to report on, but then each region could choose an additional 2 metrics that are meaningful and important to that region to work on, that kind of idea. So how would metrics work into the quality system, and who would decide? As part of our discussion today, one of the things that kind of bubbled in my head was, should we, you know, in addition to like a statewide committee that thought about metrics for quality, should we also have some sort of statewide representative committee that thought about risk adjustment and what constitutes high-risk patients? So taking that burden off of clinicians to report on diagnoses, or to systems to tell the state, instead of systems telling the state how many high needs or high risk patients they have. If there's some independent way of assessing acuity, I got really interested in that idea that somebody brought up. And should there be some sort of independent body that represented the various regions, giving input onto that? And then, we would tell every region, like, look, we've looked at your numbers, and here's your risk score for your region. Like, you're at this risk level. This is your patient population, and we'll reassess it every 2 years or whatever. But this is the risk level that we adjust it on. So ideas like that, like how could we set it up to account for differences in risk by region? Yes. So those are the kinds of things that we're hoping to continue to pull into the discussion as we continue this conversation. any other feedback, reflections, any issues you want to make sure that we talk about or bring up or elaborate on in more detail? We covered everything? Who's that? Let's see. Oh, Tony.
I think we had a calendar that kind of put a bird's eye view of kind of our direction, right? Is that, can we peek at that real quick? Is that available or?
Yes, it should be at the end of the slide deck.
Okay, I was just
So
curious, not jump ahead, but and just setting the stage for those further questions we have on down the line, and with reference to Dr. Hemming's, question on behavioral health, just setting the stage for success, or do we think we need some other subcommittees to start that conversation and thinking around those and framing that for, oral health, mental health? I didn't know if that was in the cards.
Yeah, so we need to engage more folks from the dental community to help us with the dental health question. That is an area where I think we need a lot more input and engagement from that side. So we're working on that. And then I'm working with a couple of folks at the state level on behavioral health payment ideas. I would say if folks on this committee want to volunteer for either any number of topics that they'd like to do some homework on. So quality and how quality is built into payments, or how a metric system would work, dental/oral health and how we integrate that into the universal health plan, or behavioral health payment. Those three certainly pop up right away. If you're interested in any of those, you can make yourself known, and we can think through how that work would go. Peter, I see your hand. Did you want to? Are you volunteering or have a comment?
Sorry, how about now? Okay. Both comment and yeah, I'm interested in quality assurance. So one thing that I would love to see, this is something that Cuba does, by the way, is they ask patients, they have like patient, I don't remember what it's called, but they have like teams, the patients who are receiving the services, that's a good place to ask for if the services are good. It's the people who are receiving them. So they have like councils, I think they're called. So that's one. If we're talking about how are we going to pay providers, I think it would be really important to talk to unions of the providers. I don't know if that has been done or if there's any plans for that, but the people who are actually going to be getting paid for this stuff in I think in union settings are a great way to kind of gather information rather than just like a bunch of individual providers. They have kind of it's already kind of there as a group, and they have some say in this stuff, or they should anyway. So those are just my thoughts: unions and patient committees.
So when you say unions, you're referring to unions of clinicians?
Yeah, anyone. Nurses, nurses unions here in Portland have been doing some really good stuff. So that's just, as an example, any kind of technicians or workers.
Oh yeah, so we wouldn't, nurses wouldn't be the way nurses are paid is totally different than the way clinicians are paid. And so when we talk about provider payments, we're not involving nurses. Certainly nurse practitioners are clinicians, but when you're talking about nurse unions, they're paid by hospitals. They're part of the hospital budget by and large, or the clinic that they work for. They're part of clinic care, but they're not considered providers in the way that we're talking about providers now.
So that would just be part of like the hospital piece of the pie. And then the hospital gets to choose however they want to divide that.
That doesn't mean they wouldn't have a perspective though.
Of course not. Yeah, of course they have a perspective. Yeah. I'm not sure how much, well, yeah, certainly. So this came up last meeting too, and the task force did a whole lot of engagement with the public and with various interest groups. And there is a separate committee of this board, the Community Engagement and Communications Committee, and they have a list of we're calling them interest groups, folks who are, deeply interested and invested in our work, including large businesses, small businesses, tribes, healthcare providers. There's a whole list of them, and it's that committee's responsibility to reach out and talk to those groups about various plans. And so how this is intended to work is that we come up with ideas or proposals, straw proposals. For instance, we come up with a straw proposal of how we think we will be paying providers, and then we would give that idea to the community engagement committee, and it's their job to go out and shop it around, right? And so they would talk to nurses and provider groups and hospitals and say, look, this is what they're talking about doing. What do you think of this? Poke some holes in it, give us some feedback, right? So it's the role of that committee to sort of shop our ideas around. We don't do that as part of this committee. We have a whole group dedicated to that. So our job is to come up with the best ideas we have. And everything we're doing in this committee is a straw proposal, meaning it's not the final. It's just, let's put something down on paper and then let's start putting it in front of people and getting reaction to it. So yes, we will have that engagement, but we got to just come up with something first. Somebody's hand is up. I can't see who. Oh, is that Jim?
Yeah, I just wanted to volunteer to help out in between, probably on quality.
Okay, so far we've got Peter and Jim for quality.
I'd be interested in behavioral health.
Okay, great. Rosemary for behavioral health.
Oh, is there a behavioral health group? I didn't know. I didn't see it's on the list.
Yeah, so for payment, so we already had the behavioral health group in terms of benefits, but thinking about how behavioral health is paid. Yeah.
Okay. Yeah. I'm in behavioral health, so I'll switch me to that one.
Anyone else for ideas of future topics or want to volunteer?
This is Angela. I'll do quality.
Cool. And then you're not limited to just this meeting. If anybody wants to jump in, I think you can email. Isabel, do they email the info email, or who should they email if they want to?
It's fine. They can email me directly or the info inbox, or maybe it'll come to us.
Okay. And how we've done it with the other subgroup is, like, once we've identified who's in the subgroup, we can send out a generic email with the topic and the questions that we have for you. So staff and I can come up with some questions, for instance, for the quality group or for the behavioral health payment group, and say, here are the questions that we think, are worth tackling. Do some background research. Again, subcommittees do not come up with recommendations. What they do is do some background research and investigate. And then, like Tony did today, come to this group and present their information. And then we as a committee are charged with coming up with some recommendations for the board. So be just doing some background research and presenting information on those topics. So we have oral health, behavioral health, payments, and quality, how quality fits into payments. If anyone else wants to volunteer for those now, or you can email Isabel after the meeting. Cool. Any other feedback, ideas, topics you want us to explore? Great. Then I think we have some public comment. Isabel, I'll hand it over to you to unmute people and allow public comment. And I want to thank all of the committee members for an excellent meeting. Thank you very much for all of your participation and involvement. That was really great and really helpful. We have a lot of notes. And then I will remind our folks from the public who are giving public comment that you have 2 minutes each, and we'll let you know when your time is up, but go ahead.
Thank you. Yes, so just as a reminder for everyone, we really appreciate members of the public taking their time to give input on the work of the committees and the board in general. And public comment can be submitted at any time via our website. For written testimony, we ask that people submit 72 hours prior to the meeting. And for oral comment, like we're doing right now. We ask that people sign up at least 24 hours in advance so that we can plan accordingly. And as Chair Blanca mentioned, we will limit comments to around 2 minutes. We'll display a timer. And when the timer wraps up, we ask that you wrap up your comments as well, and may need to politely interrupt and move things along if you go over time. But if you cannot share everything you'd like to share today, please feel free to sign up for future public comment at another meeting or to submit additional information via written testimony. So we have 2 people today signed up for public comment, and as soon as I get the timer on the screen, I will pass it over to Lou to share their comment.
Okay, thank you. It's good seeing you all again. It's quite a chore to go through, 3 hours or more of comments and brainstorming. I just want to remind everybody that our total experience for medical care has come through our experience only with health insurance companies. So, it kind of it's kind of mind-boggling that we're captured in their phraseology and how they think about things. But remember, they think about things ultimately to make a profit. So I think it's necessary to really keep the payment plan simple as possible, because the more options and the more of these, the more cluttered it'll be, and that increases administration. Remember, right, you know how much administration has developed over the years through the insurance companies. So keep it simple, please. Remember, all claims for payment will go to a central location. Perhaps you could look at that as a control factor, quality control or assessment, okay? And remember, you don't need to come up with all the answers right now. You just need to come up with a program you believe will work, because every universal plan is continually adjusting their plan. Every country that's doing that is always adjusting it. And lastly, I'd like to say that primary care, most people are healthy most of the time. So primary care is a way to keep people healthy, right? In Japan, I believe they direct clients to go to their primary physician first. So that you could consider that. And outside of that, thank you for my 2 minutes, and thank you for doing this work. I know it's taken a lot out of your daily lives, as it is mine. So, and yours even more. And I really appreciate the expertise and professionalism of this group. Thank you.
Thank you, Lou.
Thank you, Lou. And our next comment comes from Colin Stackhouse.
Hello, can you see and hear me?
Mhm.
Hi, yeah, thanks. I'm Colin Stackhouse. I am a member of the Community Engagement and Communications Committee, and I also work with Healthcare for All Oregon, but I'm not speaking in that context right now, just sort of giving my opinion on our eligibility. And another little sidebar caveat, I haven't been watching all of your 3-hour meetings enough to know if you've really dived into this issue entirely, but I really encourage you to consider not extending the possibility of eligibility into this plan to people that live outside of the state of Oregon. I think that even though I heard from the finance and revenue team that there's an estimate, I can't remember if it's between 7 and 17% of like the revenue that we need could come from folks that are employed through Oregon organizations or even the state of Oregon, but happen to live in Washington or Idaho or California or whatever. It's too complicated. It will be very challenging to try to bring people into the system if they're like, oh, you could participate if your employer opts in or like whatever. This is a land and a space-based goal to create a universal healthcare plan for every person who lives in the state of Oregon. and we can't offer that to people in Washington. I think like the politics, especially the last couple of days, like shows that we can, it's hard to rely on people that don't live in this state. So that's my hope for this group. You could spend 20 seconds and let me know if you've already talked about this.
Yes. Yeah.
Yeah,
Thanks, Don.
great.
Yeah, we have. So our straw proposal included a recommendation that we not cover folks who work in Oregon but live out of state. That was in the proposal that we submitted to the board. However, there are a lot of folks who do rely on their Oregon employers for health insurance, and we wanted to make some accommodation for that. So the ideas we had were sort of suggesting a broker or a stipend for those employees to purchase healthcare in their home state. But yes, yeah, we did not include non-residents in the plan.
Thank you.
Thanks for providing testimony. Great. And I believe that wraps up the meeting. So thank you all so much again for your participation and your smart comments and all your ideas. And we look forward to seeing you in August. And folks on subcommittees, you'll be hearing from Isabel. Thank you very much. Have a good day.